Good evening, dear doctors. I am Dr. Vidhya, Faculty of Obstetrics and Gynecology. So, as a part of NEET QRP, we'll discuss few important MCQ points on ovarian cancer. Okay, so oncology is a very important topic, and every year we get around 4 to 5 questions from oncology alone. So, you all know the most important is cervical cancer, but cervical cancer is little easy to understand when compared to ovarian cancer. So, I thought we'll discuss ovarian cancer first. So, here we will be discussing some important salient points on ovarian cancer, and we will also be discussing some MCQs related to ovarian cancer. Okay. So, with how to evaluate adnexal mass. Okay. Now, very often we get questions like a 23-year-old, 25-year-old woman in the reproductive age group who is regularly menstruating comes with an adnexal mass or an adnexal cyst in the first half of the menstrual cycle or second half of the menstrual cycle, and what has to be done next. And the options will be like tumor markers, follow-up, serial ultrasound, or immediate cystectomy, or TAH with BSO, or something like that. Okay. So, whenever this question comes, students, you all don't have to panic at all. Okay. I will tell you how to approach a case of adnexal mass or an adnexal cyst. Okay. Fine. So, now coming to this scenario, adnexal mass or an adnexal cyst. First of all, when you get a history like that, okay, you first see whether the examiner has mentioned a solid cyst or a simple cyst. I mean, whether the mass is cystic or solid in nature. Okay. Accordingly, you divide the adnexal mass into solid and cystic mass. Okay. Divide this into solid and cystic mass. Okay. In case the examiner has mentioned a solid mass, please remember, solid masses are never physiological. They are never physiological. Solid masses are always pathological. They are always pathological. Okay. They definitely require evaluation. Okay. And solid masses can be due to what all? Solid masses can be fibroids in the adnexa, like fibroids involving the ovary, ovarian fibroids, or fibroid involving the broad ligament fibroids. Okay. So, they can be fibroids, or they can be ovarian tumors, which can either be a benign tumor or it can be a malignant tumor. You understand? So, they can either be fibroids or they can be tumors, and this tumor can be a benign tumor or a malignant tumor. So, whenever the examiner gives you such a history, you have to definitely evaluate the patient with tumor markers. Okay, fine. But this is not the scenario which you often encounter in the exam. Rather, most of the adnexal masses are cystic masses. Most of the adnexal masses are cystic masses. Okay. So, most of the time you get a history like a 25-year-old or a 35-year-old lady comes with a cyst in the adnexa. Okay. And this cyst, say it measures 5 centimeter or 6 centimeter, and something related to the menstrual history, like she is a regularly menstruating lady, she comes in the first half of the menstrual cycle or second half of the menstrual cycle. Some details on the menstrual cycle would always be there along with this cystic mass. Okay. Now, if at all you get a question like this, how to go about it? Even in the recent FMGE exam, we had one question like this. I'll tell you. Okay. Now, whenever it's a cystic mass, please remember, it can either be a physiological cyst, okay, or it can be a pathological cyst. Physiological or a pathological cyst. Okay. What I told you is, whenever the mass is a solid mass, it's always pathological. Whenever it's cystic, it can either be physiological or pathological. So, you know what I mean by the word cyst, right? Cyst means fluid filled. Okay. Now, when do I call it a physiological cyst and when do I call it a pathological cyst? Look at the nature of the cyst in ultrasound. Okay. So, what is the first investigation that you will perform? Ultrasound is the first investigation that you will perform whenever there is a cyst present in the adnexa on physical examination or pelvic examination. So you do a bimanual pelvic examination. It looks like there is a cyst in the adnexa. The next step would be what? Ultrasound, preferably a transvaginal ultrasound if the cyst is small and is located only in the pelvis. It should be transabdominal ultrasound if it extends above the brim and if it extends into the abdomen proper. Okay. So what will I do? I will perform an ultrasound. Either a transvaginal ultrasound or a transabdominal ultrasound depending on the size of the cyst. If it's small and within the pelvis, it's transvaginal, or if it's big, it's transabdominal. Okay, fine. Now, after you do an ultrasound, you will know the nature of the cyst. Okay. So, what do I mean by this nature of the cyst? The cyst can either be a simple cyst. The cyst can either be a simple cyst or it can be a complex cyst. Okay, it can either be a simple cyst or a complex cyst. What are the features of simple cyst? Simple cysts are usually unilocular. Simple cysts are usually unilocular. Okay, they will not have any solid components. No solid components. No internal echoes. No internal echoes. No papillary projections inside. Okay, it's a clear cyst. Simple means it should be what? Clear. A clear fluid without anything floating inside. Okay, and they are not very much vascular. They are less vascular. Okay, they are less vascular. Okay, these are the features of a simple cyst. You understand? They're clear, unilocular, no solid components, no internal echoes, and less vascular. Okay. On the other hand, we have something called complex cyst. So, complex cyst is just the opposite of a simple cyst, right? Complex cysts are multilocular, or they have solid components, or they have internal echoes, or they have papillary projections, and they are more vascular. You understand? These are the features of a complex cyst. Okay, septations. Here no septations. No septations. Here there can be septations. So, even if one among these features, even if any one is present, like say either multilocularity or internal echoes or papillary projections, if any one is present, then you would consider this to be a complex cyst. Okay. Now, why do I divide this into simple and complex cyst? Because simple cysts are otherwise called as physiological cysts. Okay. Simple cysts are physiological, more likely to be physiological. Simple cysts do not require urgent intervention. Okay. All they require is follow-up. Okay. So, what is the cause for this simple cyst? Remember, this simple cyst can either appear in the follicular phase of the menstrual cycle or luteal phase of the menstrual cycle. That means either in the first half of the menstrual cycle or in the second half of the menstrual cycle. And if it appears in the first half of the menstrual cycle, it is due to increased follicle stimulating hormone. It is due to increased FSH. And when do we have this high FSH? Whenever we give FSH for the treatment of infertility, like say for ovulation induction, we treat women with FSH. Yes. Or we give clomiphene citrate or letrozole or any drug that will increase FSH levels in the body. These are the cases where you can see simple cyst in the follicular phase, and that is called as follicular cyst. Okay. So, follicular cyst means what? Cysts that appear in the follicular phase. They are simple, clear, without any solid components, without any internal echoes. Okay. So, this is simple follicular cyst, and these simple follicular cysts are usually due to increased FSH seen in exogenous administration of FSH for ovulation induction. ovulation induction or clomiphene or letrozole. Any ovulation induction drug for that matter leads to these type of cysts in the follicular phase. Now, in contrast to this, we have one other type of simple cyst called the luteal cyst or the theca lutein cyst, which appear in the luteal phase. Okay, what are these cysts due to? What are these cysts due to? These cysts are due to an increase in luteinizing hormone. Okay, they are due to what? They are due to an increase in luteinizing hormone. Okay, so where are they usually seen? They usually seen in multiple pregnancy. In multiple pregnancy. Why in multiple pregnancy? Because you all know in multiple pregnancy there is high level of HCG, right? And HCG is an LH surrogate, no? HCG is an LH surrogate. That means HCG and LH act on the same receptor. Okay. So, HCG has all properties similar to LH and its function is also like LH. Okay. So, wherever there is high level of HCG, there is a cyst in the luteal phase and you call it theca lutein cyst. And one example is multiple pregnancy. Yes. The other condition where you have high levels of HCG is gestational trophoblastic disease. So, it includes benign gestational trophoblastic diseases like complete mole, partial mole and also malignant varieties like choriocarcinoma. In all these conditions, the HCG level is very high and in turn, it leads to the formation of theca lutein cyst, that means cyst in the luteal phase. Okay. Or otherwise, sometimes it can be seen even without these predisposing factors like multiple pregnancy or GTD. Even in a normal pregnancy, this type of cyst can appear in the luteal phase, okay, and you again call them as theca lutein cyst, okay, theca lutein cyst, or sometimes it can naturally happen in the second half of the menstrual cycle without any identifiable cause, okay. So, when do you see follicular cysts? Follicular cysts are usually seen in the first half of the menstrual cycle, in the follicular phase, and theca lutein cysts or lutein cysts are seen in the second half of the menstrual cycle. That means in the luteal phase. Okay. Now, what are we supposed to do for these cysts? These simple cysts, what are you supposed to do? Should you intervene immediately? No. All they require is only follow up. Okay. All they require is only what? Follow up. Because they spontaneously regress. Okay. They regress spontaneously. Okay. So, all they require is only follow up. Now, the question is how to follow? Follow up means what? Follow up means perform ultrasound, serial ultrasound. You understand my point? Okay. Follow up means follow up with USG. Follow up with ultrasound. You all understand my point? Okay. So, this is how you handle simple cyst. Now, I am telling you this in detail because we had one question in the last FMGE exam. Okay, the question was like to a 25-year-old woman with regular menstrual cycle comes 3 weeks after her last periods. Okay, that means 3 weeks from LMP means what? She is in the next menstrual cycle in which phase? She is in the luteal phase, right? 21 days from her LMP. So, she comes 3 weeks from her LMP, she comes with a clear cyst, okay, a clear cyst in the right adnexa measuring 4 × 5 centimeter. What should be done next? That's the question, okay. So, now all the points in the given question are in favor of simple cyst, like say she is very young, she has regular periods and she got her periods only 3 weeks back and the nature of the cyst is clear, okay. So, all these point towards what? Simple cyst. And simple cyst means it's follicular cyst or luteal cyst. Definitely it's luteal cyst because she's in the luteal phase of the menstrual cycle, right? Now, what is supposed to be done? All it requires is only follow up. Follow up means with ultrasound. So, the options were like follow up, do CA125, laparoscopic cystectomy, TAH with BSO. Okay, so here the answer is definitely follow up. Okay. Now, in contrast to this, you have another variety of cyst called complex cyst. Now, when I told this, when students saw this question, most of the students gave CA 125 as the answer. Okay. Now, when I said the answer is follow-up, the common question that students asked me is where to do CA 125. What is the indication for CA 125 then? Okay. Now, remember, CA 125 is basically a tumor marker which differentiates benign cause of complex cyst from malignant causes of complex cyst. You understand my point? That means whenever you see a complex cyst in ultrasound, okay, whenever you see a complex cyst in ultrasound, this complex cyst can either be due to benign causes or it can be due to malignant cause. You understand? A complex cyst can be a benign cyst or it can be a malignant cyst. Okay. Now, what are the benign causes of a complex cyst? The benign causes of complex cysts are endometriotic chocolate cyst, endometriotic chocolate cyst, and benign ovarian tumors. Benign ovarian tumors. Okay. Malignant cause of complex cyst is nothing but the malignant ovarian tumor. You understand my point? So, this complex cyst can either be due to a benign cause or it can be due to malignant cause, and that benign cause can either be endometriotic chocolate cyst or a benign ovarian tumor, and malignant cause is usually a malignant ovarian tumor. Okay. Now, what is the role of CA 125 here? Please remember, the normal CA 125 level is less than 35 international units. You understand? It's less than 35 international units. Okay. Now, this CA 125 can be elevated in both benign as well as malignant causes of ovarian tumor. Okay. They can be elevated in both benign as well as malignant causes of ovarian tumor. Now, in case it's benign tumor, please remember the usual CA 125 levels fall between 35 and 200. Okay. In case it's a benign tumor, what will the usual CA 125 level be? The usual CA 125 level will be between 35 and 200. Mostly in malignant cases, in most of the malignant ovarian tumors, especially epithelial ovarian tumors, the CA 125 level exceeds 200. Okay, exceeds 200. So, what is the role of CA 125 here? CA 125 is used to differentiate benign causes of complex ovarian cyst from malignant causes of complex ovarian cyst. You understand my point? Ovarian cyst or adnexal mass. You understand my point? Okay. So, when students ask me where should we go for this answer CA 125 and why is the answer only follow up in the given question, my answer will be very simple. If at all the examiner has mentioned a complex cyst instead of a simple cyst in the history, then your answer would definitely be CA 125. Perform CA 125. You understand? Yes? Okay. So, this is about evaluation of types of adnexal mass. I will tell you something more on how to evaluate an adnexal mass. Okay, how to evaluate an adnexal mass. Okay. Now, see, CA 125 alone will not definitely tell you that it's a benign ovarian tumor or an endometriotic cyst or malignant ovarian tumor. CA 125 only gives some idea on what the nature of the cyst should be. You understand my point? So, CA 125 is not a definitive criteria to tell that it is definitely a malignant tumor or it's definitely a benign tumor. It only gives you a rough idea, an idea on the nature of the cyst. Okay. So, now what is the need to differentiate benign tumor from a malignant tumor? Because the management is different. In case it's benign ovarian tumor, okay, in case it's benign ovarian tumor, all you require is only a cystectomy. Okay. in case it's endometriotic chocolate cyst or benign ovarian tumor, all you require is only a cystectomy. Whereas, if it is a malignant tumor, what you require is a staging laparotomy. Okay. So, before you operate on the patient, whenever you've decided to operate on the patient, before you operate on the patient, you need to know something about the nature of the cyst, or you need to have some idea on whether it should be a benign cyst or a malignant cyst to decide on what surgery to perform, on the patient, whether to just do a simple cystectomy or to perform a staging laparotomy. Staging laparotomy means it's an extensive procedure which includes cystectomy plus TAH with bilateral salpingo-oophorectomy plus peritoneal biopsy plus ascitic fluid or peritoneal wash for cytology plus lymph node dissection. So, it's an extensive procedure. So, for a simple cyst or for a complex cyst with benign etiology, you cannot perform such an extensive surgery, right? So, before you perform an extensive surgery, you need to have some evidence to say that it is possibly malignant. Yes or no? Yes. So, what are the criteria with which we decide on whether to perform a simple cystectomy or perform a staging laparotomy? Okay, that is what we are going to discuss now. So, what we are going to learn now is how to evaluate an adnexal mass. Okay, we have different scores, no? Like we have a risk of malignancy index score, RMI score. We have something called IOTA. We have ROMA, ROCA. I'll tell you all these. All these are basically scoring systems which will tell you whether it is a benign or a malignant cyst. So, it can only make a guess on whether it is benign or malignant. Nothing is 100% specific or confirmatory for either benign or malignant cyst. Okay. So, most commonly used one is RMI score, and the RMI score is otherwise called as risk of malignancy index. Okay. So, what is RMI? RMI means risk of malignancy index. Risk of malignancy index. Okay. So, we have two types of RMI score. One is RMI 1 and the other one is RMI 2 score. Okay. So, first I will tell you what is RMI 1 score. Okay. And in this RMI 1 score, we have ultrasound features, we have menopausal status, okay, and we also have CA 1 to 5 levels. So, what all do we use to calculate this RMI score? Ultrasound features, menopausal status and CA 1 to 5. Okay. So, first is ultrasound features. Under ultrasound features, we have 5 important points. Okay. They are multilocularity. I have written all of them here. The first one is multilocularity. The second is solid areas. The third is bilaterality. The fourth is ascites, and the fifth is intra-abdominal mets. Okay. The evidence of metastasis. Okay. So, we have 5 important ultrasound features. All of these features, if present, indicate malignancy. You understand my point? Whatever I have mentioned here, all of these features, if present, they indicate malignancy. They are multilocularity, solid areas, bilaterality, ascites and intra-abdominal mets. Okay. If they are not present, then it is more towards a benign cyst. Okay. So, now each of them will get a score of 1. Under this ultrasound feature, each of them will get a score of 1. If nothing is present, no ultrasound feature in favor of malignancy is present, then you would give a score of 0 here. Okay. Like say if the cyst is unilocular cyst, no solid components, it is unilateral, no evidence of ascites or no evidence of intra-abdominal mets, then the ultrasound score would be 0. You understand? If one of these abnormalities is present, then the score would be 1, and if more than or equal to 2 ultrasound features are present in favor of malignancy, like either multilocularity and bilaterality or ascites and solid areas, like that. Okay. Either, if 2 or more of these ultrasound features are present, then you would give a score of 3. You understand my point? Either the ultrasound score would be 0, or the ultrasound score would be 1, or the ultrasound score would be 3. You understand? Okay. Depending on how many features of malignancy are present in ultrasound. Okay. Next is menopausal status. If the lady is a premenopausal lady, you would give a score of 1, and if she is a postmenopausal lady, you would give a score of 3. Okay. So, what would you do to get the RMI score? How do you calculate the RMI score? The formula is here. Okay, RMI score is equal to ultrasound score into menopausal score into CA125. Okay, so you multiply what? Ultrasound score, the menopausal score and CA125 levels. That will finally give you the RMI score. We have one example, we have one question here. We will see the question and then we will learn. Okay, so we have something called RMI2 score. Okay, under RMI2 score, it is little different from RMI1 score, where the ultrasound features, the menopausal status and the CA125 all are same. The differentiating point is what? Here, if the ultrasound features are more than 2 in number, more than or equal to 2 in number, then the ultrasound score would be 4 rather than being 3. In RMI1 score, maximum ultrasound score is 3. Whereas in RMI2 score, the maximum ultrasound score is 4. That's it. Okay. And for menopausal score also, for RMI1 score, it is 3, and for a postmenopausal lady in RMI2, the score is 4. Okay. So, RMI1 and RMI2 are almost the same with very subtle difference. The difference being a score of 4 in postmenopausal lady if it's RMI2, and a score of 3 for a postmenopausal lady if it's RMI1. Okay. Similarly, if more than or equal to 2 ultrasound features are present, the ultrasound score would be 3 in RMI1 and ultrasound score would be 4 in RMI2. Okay. So, finally, you will multiply. RMI score is equal to ultrasound score into menopausal score into CA125. Okay. So, what is the inference? If the score is more than 200, then the cyst is possibly malignant. Possibly. Okay, I am not telling it's definitely malignant. If the score is more than 200, it's possibly malignant. So, if it's possibly malignant, what surgery would you perform? You would perform a cystectomy or a staging laparotomy? Yes, you would perform a staging laparotomy. Okay. If the RMI score is more than 200, you would perform a staging laparotomy. You understand my point? So, we have one question here. What is the RMI score of a postmenopausal woman with a CA125 of 15, ultrasound showing 6 cm bilateral cyst with multiloculation? Okay. So, first coming to ultrasound score. Are there any features of malignancy here in ultrasound? Yes, it's a bilateral lesion and multilocularity is present. See, whenever the examiner hasn't mentioned on whether she wants RMI1 or RMI2, it always means that you have to calculate RMI1 because that is the most commonly used one. You understand? Okay, always go for RMI1 unless and until the examiner particularly asks you to calculate RMI2. Okay, so here for RMI1, how many ultrasound features are there in favor of malignancy? We have 2. One is bilaterality and the other one is multilocularity. Okay, so what score would I give? 2 and more. If the number of features are 2 and more, I would give a score of 3. So, the USG score is 3. USG score is 3. Okay. She is a postmenopausal lady. So, what is the menopausal score? The menopausal score is again 3. Okay. CA125 level is 15. CA125 is 15. So, what do I do now? I multiply all the 3. So, it will be 15 cross 3 cross 3. Okay. So, 15 cross 9. What's the answer? 15 cross 9 is 135. Okay. The answer here is 135. I hope you all understand how to calculate RMI. Yes, RMI 1 for the given question is 135. So, if not RMI, what other scoring systems do we have to see whether the cyst is a benign cyst or a malignant cyst? Okay. Yeah, we have 2 other important MCQ areas here. One is Roma. Apart from RMI, we have Roma, Roca and OVA1, out of which the important ones are Roma and OVA1. Okay. So, what is this Roma? Roma is otherwise called as risk of ovarian malignancy algorithm. Okay. Risk of ovarian malignancy algorithm. Okay. What are the components in this Roma? It utilizes HE4 and CA125. Okay. Roma utilizes what? He4 and Ca125. What is this He4? He4 is human epididymis 4. Okay, He4 is human epididymis 4, and you know what is Ca125, right? Cancer antigen or carbohydrate antigen 125. That's Ca125. Okay, so utilizing these two parameters, you calculate a score, and that's Roma. If you know this, it's more than adequate. We're not using all these routinely. Okay, so just know the components of Roma. They are He4 and Ca125. Okay, next is OVA1. OVA1. How many components are there in OVA1? It's again a scoring system to see whether the adnexal cyst is a benign cyst or a malignant cyst. Okay, so we have 5 important components here. They are transthyretin, transferrin, okay, beta 2 microglobulin, apolipoprotein, and Ca125. So this is how I remember it. T2 BAC, T2 BAC, T2 BAC. Okay, so what is T2? Transthyretin, transferrin, transthyretin and transferrin. BAC BAC is for what? Beta 2 microglobulin. A is for apolipoprotein and C is for Ca125. Okay, so these are certain models with which we assess the nature of the ovarian cyst and ultimately decide on whether to perform a cystectomy or a staging laparotomy. Okay, so hope you all understand what is RMI score. Okay, next we will move on to classification and MCQs on epidemiology. Okay, so how do we classify ovarian tumors? We know we have benign tumors, we also have malignant tumors. So under each of these classifications, both benign and malignant, we have epithelial, germ cell and sex cord stromal. These are the 3 main types under both benign and malignant. We also do have other types like metastatic tumors. Okay, so epithelial, germ cell and sex cord stromal tumors. We have some important MCQs related to the epidemiology of these tumors, which we will be discussing now. Okay, so fine. Now the first question is, among these, which is the overall most common? Is it epithelial or germ cell or sex cord stromal? Yes, yes, epithelial. The overall most common is epithelial. Okay, which is the second most common? Correct, germ cell. Germ cell. Okay, and the least common is sex cord stromal. Sex cord stromal. Okay, so the most common is epithelial, the second most common is germ cell, and the least common is sex cord stromal. Okay, which is the overall most common age group? Okay, please remember, overall most common age group is postmenopausal age. Postmenopausal. So postmenopausal versus premenopausal, which is the most common age group for ovarian cancer? Postmenopausal age group is the most common age group for ovarian cancer. You all understand? Okay, that is why in RMI we get a score of 3 for a postmenopausal lady and we get a score of 1 for premenopausal lady. Okay, so that means postmenopausal women are 3 times at higher risk for developing malignant ovarian neoplasms when compared to premenopausal women. Okay, fine. So most common in the young age, among the 3, epithelial, germ cell and sex cord stromal, which is the most common in young? The answer is germ cell. Okay, germ cell. Among young women, which is more common? Germ cell is the most common. Okay, so which is the fastest growing? This is the next MCQ. Among the 3, epithelial, germ cell, sex cord stromal, which is the fastest growing? The correct answer is germ cell again. Okay, fastest growing tumor is germ cell tumor. Okay, fastest growing tumor is germ cell tumor, but that doesn't mean that germ cell is the most malignant. It is fast, it grows very fast. Okay, fine. Among the epithelial ovarian cancers, we have hereditary cancers, we also have sporadic cancers. So, which type of ovarian cancer runs in the family? Among the 3, which type of ovarian cancer runs in the family? Is it the epithelial cancer or the germ cell cancer or the sex cord stromal tumors? Yes, the one that runs in the family. The one that runs in the family is epithelial ovarian cancer. You all understand my point? The one that runs in the family is epithelial ovarian cancer. That means the common genetic syndromes like BRCA, HNPCC, like hereditary non-polyposis colon cancer, the syndromes that usually predispose to ovarian cancers, predispose to which type of ovarian cancer? It's basically epithelial ovarian cancer. Okay, and so among the epithelial ovarian cancers, what percentage of them are hereditary? What percentage of them are sporadic? Which is more common? That's the question here. Okay, so is hereditary more common or sporadic more common? What's your answer? Yes, which is more common? Hereditary epithelial ovarian cancers make only 25% of all epithelial ovarian cancers, whereas sporadic cancers make 75% of the ovarian cancers. You understand? So, which is more common? Sporadic is more common. Okay, sporadic is more common. Hereditary make only 25%, whereas sporadic cancers make 75% of epithelial ovarian cancers. Okay, and also remember, not all hereditary ovarian cancers, whether it's BRCA related or HNPCC related, not all hereditary ovarian cancers will have family history. You understand my point? Hereditary ovarian cancers can occur even without family history. Okay, so what percentage of them will have family history? Among the hereditary cancers, I'm telling. Among the hereditary cancers, what percentage of them will have family history? What percentage of them won't have family history? Remember, 60% of them will present with family history and 40% of hereditary ovarian cancers present without family history. You understand my point? 60% of hereditary cancers present with family history, 40% of the hereditary cancers present without family history. Next is borderline tumors. What are borderline tumors? I'll tell you what borderline tumors are. Borderline tumors are somewhere between benign and malignant. Okay, they're somewhere between benign and malignant, but they have malignant potential. They can anytime turn malignant. Okay, they're not as aggressive as malignant. The main difference between borderline tumors and frankly malignant tumor is that borderline tumors are not invasive, whereas frankly malignant tumors are invasive. Okay, so invasiveness is not there here. So the question is, MCQ here is, what percentage of the ovarian tumors are borderline? Okay, remember 10 to 15%. 10 to 15% of ovarian tumors are borderline tumors. Okay, 10 to 15% of the ovarian tumors are borderline tumors. Okay, next is about the most common. Which is the overall most common ovarian tumor? We have many types under epithelial, no? I think you all know. Serous, mucinous, clear cell, endometrioid, Brenner. We have many types. Among all the types, I mean, regardless of whether it is epithelial or germ cell or sex cord stromal, among all the ovarian tumors, which is the most common histological variety? What's your answer? Yes? Yes, correct. Serous cystadenoma. Overall most common ovarian tumor is serous cystadenoma. Okay, which is the most common ovarian tumor during pregnancy? Yes, most common ovarian tumor during pregnancy is serous cystadenoma again, but that serous cystadenoma remains asymptomatic. Asymptomatic most of the time. Okay, the one that usually presents with symptoms, or that means pain or torsion or whatever, is dermoid. Okay, the overall most common ovarian tumor is serous cystadenoma, and that is the most common during pregnancy too. But the most common ovarian symptomatic ovarian tumor, the most common symptomatic ovarian tumor during pregnancy is dermoid. Okay, the most common symptomatic ovarian tumor is dermoid. If that word symptomatic is not there, again the answer is serous cystadenoma. Okay, so most common, overall most common ovarian cancer. So previously the word was tumor, so it includes both benign and malignant. Now they are asking you the most common ovarian cancer, that means malignant variety. Which is the overall most common ovarian cancer? The most common ovarian cancer is serous cystadenocarcinoma. Okay, the overall most common ovarian cancer is serous cystadenocarcinoma, whereas the most common germ cell cancer is dysgerminoma. You understand? Okay, the overall most common ovarian cancer is serous cystadenocarcinoma, but the most common germ cell cancer is dysgerminoma. Which is the overall most common ovarian cancer during pregnancy? During pregnancy, which is the most common? Yes? Is it serous cystadenocarcinoma? No, it is dysgerminoma. Okay? Most common ovarian cancer during pregnancy is dysgerminoma, because pregnancy means young woman, no? Dysgerminoma is a germ cell tumor which involves young women. Yes, so most common ovarian cancer during pregnancy is dysgerminoma. Okay. Which is the most common ovarian tumor to undergo torsion? What's your answer? Which is the most common ovarian tumor to undergo torsion? The answer is dermoid. Okay, teratoma, benign teratoma is dermoid. Okay, mature cystic teratoma is dermoid. So, most common ovarian tumor to undergo torsion is dermoid. What is the mean age at diagnosis of sporadic cancers? Sporadic epithelial cancers, what is the mean age at diagnosis? The mean age at diagnosis of sporadic. When I say sporadic and hereditary, it means it's epithelial. I'm talking about epithelial, okay, because in epithelial only we have hereditary cancers, okay. So, what is the mean age at diagnosis of sporadic cancers? It is 60. The mean age at diagnosis of sporadic cancer is 60. I'm stressing on this point because familial cancers occur much earlier than sporadic cancers. Okay, familial cancers occur at least 10 years earlier than sporadic cancer. So, what is the mean age at diagnosis of familial cancers? 50 years. Okay, occur at least 10 years earlier than sporadic cancer. So, 50 or less than 50. Okay, so the mean age, this is the MCQ. What is the mean age at diagnosis of sporadic cancers? Answer is 60 years. Okay. I told you there is one other variety called borderline, which is somewhere between benign and malignant, which is not invasive. Yes. What is the mean age at diagnosis of borderline? So, borderline involves young women or elderly women? Borderline involves young women. Okay. So, usually 46 to 50. Okay. 46 to 50. So, the mean age at diagnosis of borderline tumor is 46. You understand? 46 is the single best answer. So, these are the important MCQs on epidemiology of ovarian tumors. Okay. I am quickly repeating which is the overall most common, epithelial. The second most common is germ cell. The least common is sex-cord stromal. Which is the most common age group? Postmenopausal. Most common in the young is germ cell variety. Second most common is germ cell, and the fastest growing is germ cell. Okay. So, epithelial ovarian cancers are of two varieties. One is hereditary and the other one is sporadic, which is more common. Sporadic is more common. 75% of the epithelial ovarian tumors are sporadic. Only 25% of them are hereditary. Okay. And among the hereditary tumors, 40% of them will not have family history. Okay. So, borderline tumor constitutes 10 to 15% of all ovarian tumors. The overall most common histological variety is serous cystadenoma. The overall most common variety during pregnancy is also serous cystadenoma, but the overall most symptomatic tumor during pregnancy is dermoid because it undergoes torsion during pregnancy. Okay, dermoid. Okay, which is the overall most common ovarian cancer? It's serous cystadenocarcinoma, but during pregnancy it's dysgerminoma. Okay, so which is the most common to undergo torsion? It's dermoid. Okay, so familial cancers occur earlier than sporadic cancer. Similarly, borderline tumors also occur earlier than frankly malignant tumors. So we have an MCQ here. Just see these MCQ. Which of the following statements regarding demographic factors and pelvic masses is true? Okay, so true or false type. Hereditary cancers are common than sporadic cancers. Is that correct? Hereditary cancers are common than sporadic cancers. Is that correct? No, this is not correct. This is not correct. Okay, sporadic cancers are more common. 75% of them are sporadic cancers. Okay. Familial pelvic masses mostly involve adolescent girls. No, just because they involve, they occur at least 10 years earlier than sporadic cancers doesn't mean that they involve adolescent girls. They usually involve women at the age of 40s or 50s, whereas sporadic cancers at 60s. You understand the difference? No, it's just 10 years difference. Okay, so familial pelvic masses involve near menopause, women near menopause. Okay, malignancy is a more frequent cause of pelvic mass in reproductive aged women than in postmenopausal women. I told you malignancy is more common in postmenopausal women. Overall most common age group is postmenopausal. Okay. Hereditary ovarian cancers can occur without family history. This is correct. This is correct. What percentage of them occur without family history? Yes. What percentage? 40. 40% of them occur without family history. Okay. Fine. What are the two important familial syndromes related to ovarian cancer, epithelial ovarian cancer? HNPCC and BRCA. Right? What is HNPCC? Hereditary non-polyposis colon cancer. Hereditary non-polyposis colon cancer, which is otherwise called Lynch 2. Lynch 2. Okay. HNPCC and BRCA are the two important familial syndromes associated with which one? Ovarian cancer, out of which BRCA is more related to ovarian cancer than HNPCC. Okay, fine. HNPCC is more related to endometrial cancer, but it also leads to ovarian cancer. BRCA more commonly leads to breast cancer, but it also leads to ovarian cancer. So, among these two, HNPCC versus BRCA, BRCA is more common in ovarian cancer. Okay. So, whom to subject for familial cancer screening? Okay, whom to subject for genetic testing for either BRCA or HNPCC? We have a criteria here, criteria for genetic testing. Okay, so